Hello, my name is Wendy Lomers, and we at Acclaim would like to thank you for taking the time to review this presentation. We hope that you will leave with a better understanding of the new payment system that Medicare is developing and the quality metrics that will be affecting the payments that you receive for taking care of the Medicare population. While we are not certain, we anticipate that these quality metrics will also affect the payments that you receive from other payers in the future. This presentation will focus on how MIPS will apply to the specialty of radiology. MACRA, the Medicare Access and CHIP Reauthorization Act, was passed in April of 2015 to replace the sustainable growth rate system that we all recall created a looming 20 to 25% cut that threatened physicians each year. Congress continued to delay the cuts, knowing that physicians would not be able to afford to continue providing care to Medicare recipients in light of such drastic cuts. They were seeking an alternative system to replace the SGR, and finally, in April of 2015, they passed the act known as MACRA. MACRA set up a system of very small increases to the Medicare physician fee schedule that covers the time frame within which the details of the new payment system will be worked out. It also set up the framework for the new payment system called MIPS. On May the 9th, the Federal Register included the proposed rules for MACRA, and many interested parties made comments on the proposal. The final rules will be released in November of 2016, with the first performance period starting on January the 1st, 2017. In order to be prepared, physicians need to start right now by familiarizing themselves with the various components of MIPS, so there is less to learn when the final rule is released. The final rule is expected to make minor changes and not result in a complete overhaul. You will be better prepared after you complete this review of MIPS. MIPS stands for Metric-Based Incentive Payment System. In addition to replacing the SGR, MIPS brings together many of the other programs that Medicare had in the works. As you can see, it combines PQRS, the Electronic Health Records program, and the Value-Based Modifier. The program also includes measures that attempt to gauge how efficiently physicians perform their work and use the healthcare resources. A few radiologists have participated in the Electronic Health Records program, most of which owned imaging centers where the physicians controlled their information systems. The EHR program was established to encourage physicians to computerize their health records. Radiologists have used EHRs for years, and with RIS and PACS, but the measures established to determine whether the computers were being used in a meaningful way, called MU or meaningful use measures, did not include any measures pertaining to how radiologists used their RIS PACS. Therefore, radiologists, along with other hospital-based physicians who did not have control over their computer systems, fought for an exception. Thanks to the efforts of the RBMA and ACR, along with others, they were provided that exception from the EHR program penalties associated with the failure to meet meaningful use requirements. Lastly, Medicare is encouraging physicians to participate in programs that move the payment system away from fee-for-service into alternative payment models. They would like to see the payment system change to encourage communication between the various caregivers, hoping that this communication will result in the most efficient path towards the best outcomes for the patients. Since fee-for-service does not pay for consultation between physicians, there is no financial incentive to spend time coordinating care. The alternative payment models include any system that is not primarily based on fee-for-service. We will discuss the incentives to participate in these APMs in a minute. As mentioned before, the government is spending a lot of money on researching how to measure quality, resource use, outcomes, and the like. They believe that shared financial risk will motivate physicians to do a better job of coordinating care. This is a huge project, and I believe that there will be much experimentation with alternative payment models until one or more are found to be successful and acceptable to the healthcare providers. We are facing changes in the healthcare payment mechanisms, and it is hard to predict where they might end up. MACRA provides funding for research and gives MIPS credit to providers for participating in alternative payment models. This participation will vary depending upon the integration levels of the local healthcare economy. For example, it will be easier for Geisinger to participate in an alternative payment model because most of the providers associated with them have access to a shared electronic health record. On the other end of the spectrum, it will be more difficult for a geographic region that has disparate systems that don't communicate. The key to these models is to have an efficient way to coordinate the care of the patients involved, and a shared computer system helps. The first risk sharing started decades ago with capitation for the primary care physicians. The APMs of today will go much farther by including all of the care providers into one bundled payment, sharing risk across all specialties. A challenge for sure. If you follow this logic, you can probably figure out how your specific geographic region will initiate the first APM. Knowing that all physicians are incentivized to participate in APMs, it will be important for radiologists to stay attuned to the local healthcare systems and the physicians that refer them patients so that the radiologists are included as these APMs come to fruition. They will likely be discussed in the physician's lunch area, at local medical society meetings, or even at a medical staff meeting at the hospital. The hospital is also incentivized to participate in APMs, so they may be the first to coordinate this effort in some communities. One of the most likely entry points to an APM could be through a Medicare Shared Savings Program. This program requires an ACO, a special type of integrated healthcare system, to accept responsibility for the care of a group of Medicare patients. This ACO has the opportunity to share in savings that occur when the patient's care is handled in an efficient manner. Radiologists should ask those involved in their local healthcare market if there is any chance to participate in one of the Medicare Shared Savings Programs. Since all providers involved in a Medicare Shared Savings Program share in the cost and quality metrics achieved, it will be important to have confidence in the ability of the ACO to properly manage the processes and outcomes. Lastly, I want to mention that there is a distinction between an APM and an advanced APM. The advanced APM subjects the physician to downside risk. In other words, the physician can have money taken away if the cost or outcomes of the patients are not improved. It requires a significant participation in these advanced APMs in order for the physician to avoid participation in MIPS. At this point, MIPS is described as a combination of many of the current quality systems, and you can be sure that it will morph over time. That is why understanding it now will prove beneficial in the long run, like learning the alphabet before you learn to read. It just makes it easier. So now let's review the current systems and what they look like in MIPS. Each of the current systems have certain aspects included in the four components of MIPS. PQRS and the value-based modifier is replaced with the quality metrics. The electronic health record system is replaced with advancing care information, and resource use remains similar in the new system. The clinical practice improvement activity component is new under MIPS. The current PQRS system resulted in performance scores for each physician or group practice, if reporting as a group. The individual performance scores for physicians associated with the tax identification number were combined. This information, along with the resource use data associated with a group, determined the group's value-based modifier. The value-based modifier resulted in a payment adjustment that was applied to all physician payments billed under that tax identification number from Medicare. Often, radiologists had a difficult time meeting the PQRS requirements because of the limited number of applicable PQRS measures. Some radiologists began to participate in quality clinical data registries, called a QCDR, because it improved their chances for successful reporting. The increased use of quality clinical data registries is spawned by the need to prove quality. The ACR has their near-dear registry, and other specialties have their own QCDRs. The ACR near-dear has helped radiologists meet the PQRS requirements because they add 24 measures for radiologists in addition to the CMS PQRS measures. Many of these measures are reported to the ACR through a data flow mechanism that does not require as much daily interaction as the CMS report-based PQRS measures. Going forward, there will be points awarded for QCDR participation in the new MIPS. Value-based modifiers used to only apply to large groups, But for 2016 performance period, all groups are subject to the value-based modifier. Again, this is a review of the pre-MIPS metrics. So how does the value-based modifier apply to groups? Groups whose physicians successfully report for PQRS avoid the PQRS penalty, typically 2%. For their groups, they avoid an automatic value-based modifier penalty. Even so, the quality reported through the PQRS can still result in a negative adjustment to the group's value-based modifier, which affects the group's Medicare payments. The value-based modifier is determined when CMS uses the performance scores that the individuals reported, for example, the percentage compliance with each measure. And CMS also considers the resource use data attributed to the group. When the performance scores are compared to national benchmarks, they will result in either a positive, neutral, or negative value modifier adjustment. This value-based modifier adjustment either increases or reduces the group's payments from Medicare. That is why it has been so important to comply with as many PQRS measures as possible, allowing a physician to select the 9 measures with the best performance scores. The last bullet shows the 6 cost measures used in Quality Resource Use Report, often referred to as the QRUR. As mentioned before, it is likely that only the spending per beneficiary will apply to radiology. Spending per beneficiary is based on the care provided during an inpatient hospital stay. The physician group, based on their tax identification number, that provided the highest dollar amount of care based on the allowed charges for Medicare, has that patient attributed to the group. This is often not under the radiologist's control, but even so, it is attributed to that group's tax identification number and shows up on the QRUR report. The Quality Resource Use Report, again the QRUR, is where the PQRS quality scores and the resource use scores come together to determine the value-based modifier and the payment adjustment. We will review a sample of what the QRUR might look like for a radiology group. The cost data for a radiology group will show the cost benchmarks for each measure, but will likely only have the element of cost attributed to radiology, which is the Medicare spending per beneficiary. In this case, for those patients attributed to the group, the dollars spent per beneficiary of $20,455 is slightly less than the benchmark of $20,476. Therefore, the standardized scores shows a slightly negative number. When scoring cost, having a negative score would appear to be a good situation. Ultimately, the quality data and the resource use data are combined on a quality tiering report. This scattergram is part of a QRUR report which depicts the 4 quality tiers as quadrants. The Medicare determines the payment adjustments based on where the group falls within these quadrants. The best scenario is to be in the top right quadrant, since Medicare quantifies value based on quality divided by price. The QRUR reports are available in the fall for the prior year. The 2015 reports are currently available on the CMS Enterprise Portal website. Resource use was reported in the QRUR report and are often thought of as efficiency measures. Again, value is defined as quality divided by cost or resource use, so high quality and low cost is desirable. CMS has been provided a substantial budget to spend in their effort to quantify value and also to determine how to adjust for high-risk patients who need extra care. So we can all expect this research to result in changes over time as more specialty-specific resource use metrics are developed. This component of MIPS is new and does not mimic any of the past CMS programs. I mentioned the alternative payment models before. The CPIA scoring gives credit to providers for participating in alternative payment models. CPIA requires physicians to implement improvement activities that CMS anticipates will result in improved patient outcomes. But we'll talk more about CPIA in a bit. The EHR program was established to promote the use of electronic health records with the end goal of having systems that can talk to each other. It started as an incentive program and ended with penalties for those that failed to implement the systems. In order to obtain the incentive and avoid the penalties, the program had meaningful use criteria that had to be met in stages. The industry has had a difficult time meeting these meaningful use criteria, especially in radiology, because the program was an all-or-nothing program, meaning that you had to meet every MU requirement to be successful. This program is replaced by the MIPS component called Advancing Care Information. Now that we have reviewed the CMS programs in place and how they morph into MIPS, let's review why physicians will want to participate in the new MIPS programs. First, realize that Medicare will be adjusting the payments to all physicians based on how well the physicians participate in MIPS. There will be bonuses paid to those who have higher value scores and penalties taken from those who have lower value scores. The total payments remain the same, and the money taken from some will be redistributed to others starting in 2019. There is also money set aside for those who participate in alternative payment models. Participation in alternative payment models also minimizes the efforts needed to meet PQRS requirements. The Medicare money paid each year will be adjusted based on physicians' participation in APMs. Now you understand why I say that all providers are motivated to get involved in APMs. There is the potential for a 3 times multiplier applied to those above the benchmarks. Within the range, it is determined by how many physicians are below and above the benchmarks for their region and national averages. If many are below the benchmark with fewer above, it allows those few above the benchmarks to have a higher multiplier. Still not convinced you want to be at the top of the quality value food chain? The government also set aside $500 million a year to share among those physicians who participate in all quality metrics. Early adopters will be more likely to gain a higher share of these funds. While no one can predict exactly where this metric-based incentive payment system will end up, it is important that physicians understand as much about it as possible. Quality metrics are already being monitored. Medicare has established websites that compare the quality metrics associated with each physician and each hospital who provide health care to Medicare recipients. ICD-10 was implemented so that more specificity could be provided, which is expected to help the research being performed. The detailed claims data that Medicare has is being shared with qualified entities who will work with others to analyze the data, looking to establish unique situations that might improve the cost and/or quality of care. There are also other changes anticipated for the sole purpose of gaining a better understanding of the care being provided. I mention these to make you aware of the efforts that are underway. There is a Physician Compare website that is available to anyone who wants to access it. You will want to know what yours says. While patients may not access your quality metrics because they rarely choose their radiologist, except maybe interventional radiologists and breast imagers, you can be sure that hospitals will want to view their radiologist data. I can imagine that attorneys may access the information as well. That is why it is important that you become familiar with this system and accept personal responsibility for your quality metrics. We have reviewed the pre-MIPS systems and what is at stake. Now we will look at the metric-based incentive payment system called MIPS. As we review this information, I want to remind you that these are the 2017 proposed rules and that the final rules are released around November. The MIPS scoring system is made up of 4 components, and the performance scores for each of these come together to form the MIPS Composite Performance Score, CPS. MIPS will result in all physicians being scored a number between 0 and 100. I want to be sure to give credit to the Center for Medicare and Medicaid Services for providing education on the new MIPS, which helped provide the basis for this presentation. Here is a link that will provide as an additional resource should you need further information. This shows how the current system compares to the new MIPS components. MIPS brings parts of the prior systems into play. You can see that the quality mimics the PQRS. Advancing Care Information brings in many of the EHR program requirements. One major difference between EHR and Advancing Care Information is that ACI is not an all-or-nothing system. Resource use is still compiled from claims data, but they have added a few more metrics. The new piece is the clinical practice improvement activities. We will delve into these further in a minute, but I wanted you to see how the components of the prior systems are morphing into MIPS. The new MACRA provided for two pathways. MIPS, which for the 2017 performance period will include a very large percentage of the physicians, and Advanced Alternative Payment Models called AAPMs, which is the path that will be taken by those physicians who participate in risk-sharing payment systems. For 2017, most of the AAPM participants work in integrated healthcare delivery systems, but other AAPMs are being created through research efforts, and more of these types of payment models will be added in the future. The end goal is to push the Medicare payment system away from the current fee-for-service and end up in a more integrated system that rewards value. Right now, value is based on quality and resource use, but CMS indicates that the ultimate measure is improved outcome for patients. We will now focus on the MIPS side of the new payment system, since this will apply to most physicians for 2017. Who will be participating in MIPS? We will delve into the performance categories and touch on how they will be scored. We will look at how this information will be reported to Medicare, and we will look at the performance periods and when the payment adjustments will be implemented. For year 1 and 2, you can see a list of who will be eligible. The Secretary has the ability to change the participants over time, but this is what was shown in the proposed rules. As you can see, Radiologist will be participating in year 1. Who will not be required to participate? MIPS only applies to Medicare Part B recipients, so only the physician side, not the facility side. Brand new Medicare providers in their first year of enrollment will not be eligible to participate. Low-volume Medicare providers who bill very little to the system will not be eligible to participate. And those providers who are active in advanced alternative payment models will not be participating in MIPS. Participation can be individual, or the group can choose to combine all physician scores within the same tax identification number and share those scores with all group physicians. This is similar to the prior G-Pro in that you must make the election every year by June the 30th for the current year, and the election is irrevocable after June the 30th. Again, here are the performance categories that are combined to determine the composite performance score for the physician or the group. Each of the categories is scored separately and then combined. Quality and resource use data are both compared to their respective benchmarks, which are determined when data from all participants are accumulated. This comparison determines the points that the physician or group will be eligible for in each of these two areas. The clinical practice improvement activities are reported, and the scores are determined based on the number of points that the physician or group earn as compared to the maximum available points for that component. Advancing care information has two levels of participation, a base score and a performance score, which is based on how many participation levels the physician or the group can accomplish. This is the weighting that has been assigned for year 1, which is the 2017 performance period. As you can see, the quality metrics have the heaviest weighting, and the resource use has the least weight. For the quality performance category, the 2017 quality measures align with the PQRS measures that the radiologists have been reporting for 2016. The reporting requirement proposed a drop from 9 to 6 measures, and instead of a quality domain requirement, there is now a measure type requirement. The measure type includes a label called outcome measurement, and more emphasis is given to reporting outcome measurements than the other measure types. In some cases, the physician or group can select to report on a specialty measure set, which, if successfully reported, would meet the 6 quality measure requirement even if the set included less than 6. There are also population measures that are measured by CMS using claims data, but it is not clear yet if these would apply to radiology. Since radiologists become accustomed to reporting the PQRS measures, and the new quality measures are similar, it is fortunate that the quality performance category makes up 50% of the composite performance score under MIPS for year 1. Again, the quality measures are proposed to be almost exactly the same in 2017 as they were in 2016, with a few caveats. There are still quality domains assigned to each measure, but the measure type is more meaningful in 2017 because there are requirements to include reporting on specific measure types. For example, as I mentioned, there is a requirement to report on an outcome measure. The measures have also been assigned a priority level. Note the measure type on the sample here. Each measure has been designated with symbols in the first column that tell you something about the changes. For example, an asterisk means that the existing measure was used, but it had proposed substantive changes. A plus means that it's a new proposed measure. A single exclamation point means that it is a high priority measure, and a double exclamation point means that it is a high priority measure that is also an appropriate use measure. These symbols will help you when you try to select which measures you're going to report on in 2017. There is a definition in the proposed rule for non-patient facing eligible clinicians. The contention is that these physicians have few, if any, encounters with the patients, and this potentially limits their ability to meet some of the MIPS requirements. So some concessions have been proposed. Note that radiologists fall within the proposed rule definition of a non-patient facing physician. These non-patient facing clinicians are allowed to report on specialty-specific measure sets, as mentioned before. They are also exempt from reporting a cross-cutting measure. Again, whether reporting as an individual physician or as a group, 6 measures will be required, and they must include a cross-cutting measure and an outcome measure. If no outcome measure is available for your specialty, then it can be replaced by a high priority measure. There are outcome measures available to radiology, and the proposed rule regarding non-patient facing physicians may end up eliminating the need for cross-cutting measures for radiologists. If an individual cannot find 6 measures, they should report on all available measures and the scoring will be reweighted. These requirements establish how you will select which measures from the available measures. There are also bonus points available for the quality measure component, as you can see here. Quality scores are converted to points using a decile system. Medicare will use the reported data to determine where the combined performance of all physicians falls within the decile system. If a physician or group's performance falls within a decile, then partial points will be awarded. If a measure is scored at all, it will receive a minimum of 1 point. I'll get more into it now. There is a maximum of 10 points available for any single measure. If 6 measures were not reported, then for every measure that was available but not reported, the score will be 0. So let's look at a sample showing the actual combined performance scores at the bottom. It shows how the scores fall within the deciles. As you can see, the top decile had performance scores from 86 to 100%. Anyone with performance at or above 86% will receive a 10% for this measure. A participant with a score of 19% will receive about 3.3 points. A new proposed rule called a topped-out measure works exactly the opposite of the college concept of scoring on a curve. It is likely that the most common and easiest measures will result in very high performance scores from most physicians. these will be considered topped-out measures and will result in lower scores, point scores, because of their simplicity. These measures could result in lowering the physician's overall score if these are selected, and in the end they end up being topped-out measures. Let's look at an example of a topped-out measure. As you can see, half of the eligible physicians or groups ended up with a performance score of 100%, indicating that this was an easy measure. Since the middle of the cluster is at 8.5, that will be the score that all of the physicians receive for this topped-out measure if they scored a 100% performance score. This will be difficult to predict since the results are not known until all of the performance scores are evaluated by Medicare. Here is a sample of the quality scoring for one physician, Dr. Jones. The middle column shows the performance scores for each of the quality measures reported by Dr. Jones. See measure 1, 2, and 3 with scores of 4.1, 9.3, and 10. Then in the last column you can see that these three measures were reported through an electronic health record, which provides a bonus point of 1 for each of these. For measure 5, the high priority measure, added a bonus point in column 6. Dr. Jones did not report 6 measures when he left out the cross-cutting measure. This resulted in a 0 for that measure. The fifth column indicates the total points available for each measure. When you total each of these up, you come up with 48.2 points out of a possible 70 points. But then you add 4 bonus points, which brings the total to 52.2 points out of a total of 70 possible points. This results in a 74.6 quality performance category score. Let's see how we came up with 74.6%. Here's another depiction of the same calculation. Dr. Jones gets 52.2 points out of a possible 70 total points, which results in the quality performance category score of 74.6%. Let's review the resource use summary, another MIPS component. There is no special reporting for this component since Medicare uses the claims data to evaluate spending in different areas. The proposed rule added more than 40 new episode-specific measures to help cover additional specialties. Again, the physician or group data is compared to national benchmarks to determine performance. The weighting for 2017 is 10% for the resource use component. Here are a few of the measures that have been utilized so far. For radiologists, the Medicare spending per beneficiary measure has shown up in the past. Until recently, most of the measures have been most relevant for physicians who provide some form of primary or specialty care, not the consultant physicians. Clinical practice improvement activities is a new category, and it is referred to as CPIA. This category gives special credit for physicians who are part of a patient-centered medical home because these entities have internal improvement activities in place. For radiologists, there are several CPIAs listed in the proposed rules that are relevant. Participation in a qualified clinical data registry provides access to CPIAs. I will show you an example of a CPIA in a second. I mentioned non-patient-facing clinicians earlier and said that there was special consideration given to these in the proposed rules. The Secretary was given the latitude to make concessions such as revaluing components that are difficult if not impossible for non-patient-facing clinicians to meet. These might help radiologists who find it difficult to comply with some of the CPIAs. Here are some of the concessions that were proposed. Again, the Secretary has discretion in this area, so we will wait and see what happens in the final rule. Here are the subcategories that describe the various clinical practice improvement activities. In addition to subcategories, all CPIA have been assigned a medium or high value weighting. The selection of activities will be based on these weightings. As promised, is a sample of a few CPIAs that are available. More of these can be found in the appendix of the Federal Register. There are over 90 activities listed in the Federal Register in the proposed rules. Here's another example. Note the different subcategory and the high weighting. Now we will look at the Advancing Care Information component. This shows how the ACI is scored. There is a base score, a performance score, and the possibility of a bonus point. If a physician or group earns 100 or more ACI points, they will receive the full 25 ACI points available for the ACI component. Here are the 6 objectives for the base ACI score, which is a maximum of 50 points. As you can see, this component was derived from the Electronic Health Record Incentive Program of the past. Each of these objectives focus on using technology to interact with the patient and the healthcare system in general. As you can see below each area, there is a short description of how that objective will be reported. Some result in percentages, and others are simply attestations stating that you accomplished the objective. Further, there are another 80 points available for additional activities in these areas. The difference is that the new ACI provides the opportunity to earn points in many areas, and it replaces the prior all or nothing reporting that was used by the old EHR incentive system. This will help specialists such as radiology meet some portion of the ACI performance score. Again, this component focuses on how physicians utilize the IT systems to meet certain objectives. It allows partial credit. It has included some specialty-specific objectives. In addition, Medicare made a special effort to eliminate measures that were redundant and appeared in several systems such as the EHR and PQRS. For some reason, Medicare eliminated the objectives that might have been met by the requirement to use a clinical decision support system or a computerized physician order entry system. We will see how that pans out in the final rule. This component is weighted at 25%. So let's talk about the performance periods and the payment adjustment periods. 2017 is the initial performance period for MIPS, with the payment adjustments for 2017 performance being applied to the 2019 Medicare payments. This 2-year cycle repeats itself going forward. This is a summary of the 4 components of MIPS that includes the point system, the weighting, and a brief description on how the scoring is applied. It makes a great reference tool, and if I were you, I would probably print it out. So each component has various ways to submit the MIPS data to Medicare. Here are the ways that the quality data can be sent. For radiology, the most common way to submit data is through a registry. This can be a qualified registry or a qualified clinical data registry. Physicians who see patients often have electronic health records that record data such as the last flu vaccine. This data can then be submitted directly from the EHR to Medicare, hence offering them some bonus points. There are also some measures that are calculated based on claims data. Resource use data is always accumulated by Medicare using claims data. There's no reporting requirement. Advancing care information requires a combination of reporting mechanisms. Some will require the physician or group to report what percentage of their patients achieved an objective, such as having access to their electronic health record, and others simply require that the physician attest to a specific requirement. Clinical practice improvement activities are also reported using a combination of various reporting mechanisms. MIPS is a payment system, so let's review how it affects the physician or the group's payments. Remember that the MIPS threshold is determined by the overall performance of all physicians participating in MIPS. If the individual physician or the group's composite performance score is at or above the MIPS threshold, then there is the potential that the physician or the group's Medicare Part B payments 2 years later will be adjusted upward from 0 to 12%. There is also an additional $500 million per year that will be distributed to the top performers. If the CPS, the composite performance score, is below the MIPS threshold, then there will be up to a negative 4% payment adjustment applied to the physician or the group's Medicare Part B payments 2 years after the performance period. The 2019 payments adjusted as a result of the 2017 performance. Since MIPS is a budget-neutral system, the high performers will benefit at the expense of the low performers. This shows the maximum positive and negative payment adjustments for each of the years shown. Note that there is language that will allow the upside adjustment to be 3 times the downside adjustment as long as the system stays budget neutral. This will depend on how many physicians and groups begin to participate and how well they perform. Here is the distribution and how the payment adjustments will be applied based on where the physicians or the group's performance falls as compared to the MIPS performance threshold. It also shows that the top 25th percentile will be eligible to share in the additional $500 million per year, and the lowest 25th percentile will receive the maximum negative payment adjustment each year. The payment system is changing. The first MIPS performance period will begin January 1, 2017, resulting in payment adjustments of the 2019 Medicare Part B payments to physicians and groups. Almost all radiologists will be required to participate in MIPS. Only a small number of brand new radiologists or a small percentage of radiologists who are part of an integrated healthcare delivery system will not be participating in MIPS. Now is the time to become familiar with the terms associated with MIPS. It will make the final rules easier to interpret and apply. In order to maximize reimbursement, each physician and group is responsible for ensuring that they endeavor to have the highest possible performance scores in MIPS. As mentioned before, the quality metrics that we have discussed are reflected on a Physician Compare website that is maintained by Medicare and available on the Internet. These are some of the other metrics that are shown. Medicare is seeking quality metrics on all physicians and has stated that they will populate this website with information from other reliable sources. The QCDR mentioned here is a qualified clinical data registry, such as the ACR's National Radiology Data Registry, known as NERDIR, which includes a dose index registry, the National Mammography Database, along with other registries. If you would like further information on the Physician Compare website, the CMS offers webinars on this and many other subjects at the link printed at the bottom. This Physician Compare website has a parallel website called Hospital Compare, so know that the physicians are not the only ones in healthcare meeting quality metrics. Hospitals are seeking metrics for all departments, and they should be amenable to assisting the radiologist with quality initiatives as the Medicare payment system transitions from a fee-for-service system to a value-based system. Each physician and group is responsible for watching their quality metrics. I am sure that this all sounds very daunting, like learning a new language. Don't despair. Your efforts to become more familiar with these changes places you ahead of the game. The systems are being developed, and the most important thing that you can do is stay attuned to the changes. I hope that you feel your time was well spent. The changes in healthcare and their efforts on radiology will continue, and hopefully we can journey through them together. Always feel free to call us here at Acclaim if you have questions or concerns. We are here to help you.